We're going to finish up today's lecture by going into brainstem region. So brainstem, remember we talked about just a moment ago, we have midbrain, pons, and medulla, right? So those are the three major regions of the brainstem. And you're also going to find that your cranial nerves come off of the brainstem as well. So that's why one of the main reasons why the brainstem is so important. Other things that the brainstem does, it's going to be helping to regulate a lot of your autonomic activity. So breathing, respiratory rate, that's going to be moderated by the brainstem, right? Both the pons and the medulla are going to have regions in there that help to moderate how fast or how slow you breathe. There's also going to be areas within the medulla that are going to help regulate your pulse rate, right? How fast your heart is beating. So extremely important part of your body. When we get into blood circulation, like blood flow and all that, next time we meet in part 3, then we're going to talk about what type of symptoms you might see from like different types of strokes, right? I'm not going to go into like full detail about all the brainstem strokes, but there's a bunch. And some of them are really scary. Like the worst of them is locked-in syndrome, which is a stroke that affects the blood supply to the pons. Have you guys ever heard of locked-in syndrome? Locked-in syndrome, I'm going to show you a video of that next time we meet. It's a scary condition because literally you are completely fully conscious, but you can't move anything in your body except for maybe your eyes and maybe your eyelids. But there's even complete locked-in syndrome where some people can't even do that. So locked-in syndrome, if you have a stroke to the pons or if you have any sort of like trauma that damages the pons, some people live like that for the rest of their lives, literally not able to do anything with their bodies. There's a couple of really famous cases of people who have made recovery from locked-in syndrome. There's a book also, I forget the author's name off the top of my head, but I included in that whole section on locked-in syndrome. He was able to eventually start communicating with his eyes to the point where he could actually write that whole book, right? So it's kind of like an autobiography of his experience with locked-in syndrome. So the brainstem is an extremely important part of the body. Another thing that I might include at some point during this class, I'm still debating on that, is how to diagnose brain death. So one of the things that you do to diagnose brain death is you do like a cranial nerve type of test on a person. And this is one of the things that that's one of the experiences that I had that really convinced me that I did not want to do neurology. My preceptor, there was this lady, my preceptor and I and a couple of the other medical students in neurology, we had to go to this floor where a lady was hooked up to a ventilator, right? So she was kept artificially alive with a ventilator device. She had disseminated intravascular coagulation, DIC. Some people refer to it as death is coming, because if you have DIC, that's really bad. You're probably not going to survive. And she had it because she had blood cancer. So she had AML. So that's a type of leukemia. And it's an acute type of leukemia. And so she got DIC secondary to that. So what happens when you get DIC? You basically, everything clots up, right? So all of your clotting factors are used up. So you get blood clots everywhere in your organs, tissues. And then all of a sudden you start getting bleeds because after everything gets used up, now there's no more things left to control the bleed, right? So you used up all your platelets, you used up all your clotting factors. So DIC is a horrible condition. Like I said, most people don't survive. And so we had to go down there and diagnose this lady with brain death. And, you do all the cranial nerves. We even do like the corneal reflex where you like touch the cornea to see if there's any pain sensation in the cornea. If they don't blink, then they don't have that reflex anymore. And then you basically go all the way down the brainstem along all the different like cranial nerves. And one of the things that creeped me out the most was the doctor was on the other side of the bed. I was on one side of the bed. And you do it's a procedure called like doll's eyes. And normally speaking, if you're looking ahead, right, and you move your head, usually your eyes remain focused on an object in the room. And so when you move your head, even if someone were to like shift your head over, your eyes are still going to move, right? They're going to move, but they're going to remain fixed on an object. But if they move your head suddenly and your eyes move with your head, that's a really bad sign. That means that you've lost the majority of your brainstem functions. And so he shifted over the patient's head really quick, and then she just locked eyes with me and just like staring straight at me. I'm just like totally creeped out. It gave me the heebie-jeebies. I was like, this dead lady is staring at me. And that was like one of the last tests that we did on this patient. And then when we had to go down to the room where the family members were waiting, and we had to tell them that the mom is dead. She had like 3 kids. It was a horrible day. And after all was said and done, we're like walking around with the neurologist, and he noticed, you could tell that we were all just like depressed about it. He's like, trust me, guys, it's not always just depressing. I'm like, I don't know, dude. It's been pretty damn depressing. Stroke patients, declaring brain death on this poor patient, having to tell her family that, she's dead. It was horrible. Anyway, so that's one of the things that you do with the brainstem. You do like a whole entire evaluation if you're diagnosing brain death and stuff. So here's an overview again, same exact overview as I had previously, but now we're getting towards brainstem and cranial nerves. So that's the major difference here. So I'm going to skip a lot of this, and we're going to go back to it later. But what I really want to focus on today, I want to make today a little bit fun since it was pretty lecture heavy. Let's do the cranial nerves real quick, and let's do cranial nerve tests on each other, okay? So let me pull up this chart over here, and this is going to give you all the cranial nerves listed 1 through 12, okay? So there's 12 cranial nerves. They all come off of different parts of the brainstem, okay? And they're labeled 1 through 12, and let me actually pull up a slide just showing where they come off of the brainstem. So this is where all the cranial nerves come off of. And don't pay attention to these numbers. These numbers are not correct. Pay attention to these numbers over here. So it doesn't show the olfactory bulb because the olfactory bulb doesn't go here. It's going to go directly, gets directly encoded into memory, right? Bypasses the thalamus. Otherwise, all the other cranial nerves are going to be seen on the brainstem, and they start superiorly and they move down inferiorly. So you start off with cranial nerve 2, which is going to be your optic chiasm, right? So that's going to be how you are able to see, right? So it's going to be sensory input only, right? Then you move down to cranial nerve 3, which is your ocular motor nerve, and that's going to involve motor function. So it's going to innervate different muscles that are your extraocular muscles. So whenever you move your eyes around, the majority of those muscles are going to be innervated by cranial nerve 3. And then also accommodation reflex, pupillary dilation and constriction, that's cranial nerve number 3. If you have cranial nerve 3 damage, you're not going to be able to dilate your pupil, constrict your pupil, okay? Or accommodate. Accommodation is when your pupils dilate when you look far away. When you're looking at objects up close, you don't need as much information coming in, right? The object is really close to you. Your pupils constrict when you're looking up close. As soon as you look at something far away, you're bringing in more information from your environment. Your pupils are going to dilate. So you should be able to see that. Cranial nerves 4 and 6 are also going to innervate the muscles of the eyes. 4 is the trochlear nerve, and it's going to innervate the superior oblique muscle. What does the superior oblique muscle do? It's going to move around. It's going to latch onto the trochlea, which is going to be like a little hinge, and it's going to latch around that hinge, and it's going to grab onto your eye, and it's going to allow you to be able to look down and out, okay? So if you can look down and out over to a corner, that's because of your trochlear nerve. That's because of your superior oblique muscle. And then your abducens muscle, abduction versus adduction. You guys are familiar with those terms? What's abduction? Abduction. Yeah, right. It's like you're getting abducted by aliens, right? Abduction, taking away from the midline. The abducens nerve does exactly that. It moves your eye away from the midline, right? So your lateral rectus muscles on the lateral sides of your skull or your orbit, right, that provide musculature to your eye, that's going to allow for lateral movement of the eye. Then you have facial nerve. So you have facial nerve and the trigeminal nerve. Trigeminal is cranial nerve 5. That's going to it's going to be both sensory and motor. It's going to provide sensations to the face, and it's also going to provide muscle movement for the muscles of mastication. So if you clench your jaw, all right, that's going to be cranial nerve 5, right? Other muscles of expression, on the other hand, like if you smile, if you grimace, and all that other stuff, that's going to be cranial nerve 7. And cranial nerve 7 is the nerve of expression, right? So you can get all of your other facial muscles by the use of cranial nerve 7. Then you get down to your vestibular cochlear. That's going to be your ability to both hear, right? That's a cochlear side. And then the vestibular side is balance, right? So if you have any sort of damage to the vestibular nerve, you're going to have what, you think? What's a term for when you feel like the world is spinning? Vertigo. Good, exactly. So if you have damage to the vestibular cochlear nerve, you could get maybe tinnitus, right? Because you might start hearing ringing, right? You might have some hearing loss. And if you get a damage to the vestibular side, you'll get vertigo. Cranial nerve 9 is going to be your glossopharyngeal nerve. It's going to innervate. It's going to provide taste sensation on your tongue. And it's also going to innervate a lot of the muscles for like swallowing, right? So if you're swallowing, it's going to involve a lot of pharyngeal muscles. And so that's going to be cranial nerve 9. Vagus nerve is going to be a lot of your autonomic activity throughout like your viscera. It's going to innervate your heart. It's going to innervate your stomach. It's going to innervate parts of your GI tract. It's going to innervate your bladder. Right, so cranial nerve 10 is really important for a lot of different things like peristalsis in the large intestines, things like that. Cranial nerve 11 is the most boring of them all. It's the accessory nerve, and it innervates the trapezius muscles, right? Latissimus dorsi. It allows you to like shrug up your shoulders. So kind of boring. Then you have your hypoglossal nerve, and one of the main things it does is protrudes your tongue. Okay, so whenever you're able to protrude your tongue out, that is going to be your hypoglossal nerve. Cranial nerve 7 also provides taste to the tongue. The tongue is going to be divided in 2 sections. It's going to be the anterior 2/3 of your tongue and then the posterior 1/3 of your tongue. Posterior 1/3 is going to be your hypoglossal. And then your, glossopharyngeal. Cranial nerve 9, and then cranial nerve 7 is going to be the anterior 2/3. Okay, and then 12 here, that shows that, protruding the tongue out, right? That's going to be cranial nerve 12. So let's do some tests on each other. Mostly it's going to be optic, right? But partner up, hang out with your favorite partner, and then I'm going to get one of you, I'm going to have you be my partner. Is that okay? And then we'll do some, I'll do my, all the tests for your eyes and stuff with you, and then you guys can basically do the same thing with each other, okay? So if you want to come up over here. So with olfactory, I don't have anything in here that, maybe some alcohol from like the hand sanitizer, if you're able to smell it, right? That's one way to test the olfactory nerve, if you can actually smell, right? Did anybody lose their sense of smell if they had COVID a couple years back? When I first had COVID, I lost my sense of smell. The reason is because within your olfactory bulb, you have a lot of ACE receptors, and that's where the coronavirus bound to. And so that's why a lot of people lost their sense of smell. And smell is tightly associated with taste. So if you lose your sense of smell, you might also lose a lot of your taste as well. So we're not going to do olfactory, but we'll do optic. Do you have, I guess first of all, can you see, look at me. Can you see my fingers move?
Yeah.
All right. Can you see my fingers move here?
Yeah.
Okay, cool. How many fingers am I holding up?
2.
Cool. How many fingers am I holding up?
2, 3.
Good. How many fingers am I holding up?
4.
Awesome. How many fingers am I holding up?
2, 3, 1.
1. Okay, cool. So his peripheral vision is good. I tested all 4 quadrants of his vision, right? So if he had any sort of damage to the optic nerve, then you might see some, blind spots, basically. You guys learned endocrinology already, right? What's one thing that might affect the optic nerve? The optic chiasm specifically.
You're right down. Give us a hint.
Okay, so here's a patient. He's a 40-year-old man. He's been lactating, which is kind of unusual for a guy. He also is complaining of changes in his vision, and he's been having lots of headaches lately. What causes lactation? What's the,
Estrogen.
Well, there's another hormone. Starts with a P. Prolactin, good. So prolactinoma is going to be one of the most common types of pineal gland tumors. And so if he had a pineal gland tumor for whatever reason, he might be complaining of vision loss. And the optic nerve, it's going to cross at the optic chiasm. But not all the fibers cross, only certain fibers cross. The ones that are going to be responsible for peripheral vision, those are the ones that cross at the chiasm that come in close contact with the pineal gland. So if you have a pineal gland tumor, you're going to lose your peripheral vision. So you wouldn't be able to see my fingers move if you did the peripheral vision test. So that's good. You don't have any optic nerve damage. Let's do now ocular motor, trochlear, and abducens nerve. And you guys can partner up and watch me do it first, and then you guys can do it to each other. So follow my finger, okay? So change my hand. So that's the H test. So you literally draw an H, and you have the patient follow your finger the entire time. Now the other thing I'm going to have you do is keep staring at my finger. Keep staring at my finger. Good. All right. So you got convergence, which is where you follow the finger, and if you start going cross-eyed, that means convergence. And then if I had a pen light, which I mean I can use my phone. Dang. Hope this is not going to interfere with my recording. So you have is there a light on there?
Oh, no.
Yeah. So a pen light would be one way to do a test, but you can use your phone light as well. So keep looking at me. So it's kind of hard to see with the room is kind of dark, so your pupils are probably already constricted. But if you had lighter eyes, it would be even easier to see. But you might want to turn the lights down a little bit in the room so you can see. The pupils will dilate just naturally because you're in a dark room, so then the pen light will be a little bit more effective so you can see pupillary constriction. Another thing that you could do too is you can have the person look at your finger up close. So let me try to look at your eye. Pupils. Look at my finger up close, and now look at the far side of the wall. So your eyes dilated a little bit, so that's going to be the accommodation reflex. So if you look at an object up close, it's going to be constricted, and as soon as you look at something far away, you should see the pupils dilate a little bit, and so that's going to be accommodation. Go ahead and do that test with each other real quick before we move on to some of the others. So partner up. Do you want to do it on me?
Yeah. Might as well.
All right.
Which one? Do
Let's do the optic nerve first.
optic? What was
So,
that? Like the numbers?
How many fingers am I holding up? Yeah.
Okay.
3?
Yeah.
Okay. 4?
Yeah.
2?
Yeah.
3?
Yeah.
Sweet. 3?
Yeah.
All right, cool. All right, I'm not blind.
I
I mean, I'm kind of blind.
I was getting them wrong. I'm like, I couldn't see it where you had it at. I'm like,
I think I might have had it a little bit too far out. All right, what's the other one that you were going to do?
The one that you just, I think it was like,
Okay, so that's convergence. Good.
And then there was the one where you
There's also, yeah, there's that too, but do the H one first. So you start off with H. So I'll follow your finger.
Oh yeah, it is easy to tell. You also have light eyes, so that's easier to tell.
Okay. Cool. And then my eyes are dark too, so it's kind of hard to see if.
Yeah.
But can you see my eyes?
I can use my phone.
Yeah, go ahead. See if my pupil dilates or constricts. So you can come in from the side.
Yeah.
So what you do is you kind of like start laterally, and then you move to the front, and then you should see my.
See it go
It should
far.
be dilated when it's out to the side, and once you get closer, then it should be constricted.
Okay.
Yep. Cool. And then with your light off to the side, so if you have your light shined off to the side, it shouldn't make my eyes move, but you should be able to see my pupils. Like, see if my pupils change size. I'm looking at my finger now.
I feel like the eyes crossing.
No, I can't see it that much.
Yeah.
No, it's so much easier if somebody has like blue eyes.
Oh, okay.
Like I did this with my colleague, Professor Barton, Michael Barton, and his eyes are blue-ish, and so it's really easy to see like the accommodation reflex. The accommodation reflex, where you have the person stare at your finger up close and then look at a object far away in the room. And so the lighter your eyes, the easier, right? So you got blue eyes, it makes it way easier.
You could see mine.
You could see yours. Did you see the accommodation reflex up close versus far away?
I didn't try that one though.
Try
I'm
it. See.
really blind. I can't do the peripheral very much.
I'm pretty blind too. Yeah.
On the blind side here.
Yeah, I feel like they got bigger.
Okay, so I'll give you guys one more minute to do those tests on each other.
Yeah.
It's so cold outside. I'm not ready to go back inside. I prefer the cold rain. No, absolutely not.
All right, so with vestibular cochlear test, you can be behind your patient, not in an awkward way or anything, but so they're not seeing your hands, right? And then you ask them, can you hear the sound?
Yeah. Yeah.
Which side?
Left. Right.
Good. So that's like you can test their hearing. There's obviously if you suspect that the person has any hearing damage, you take them to get a proper test, right? That's just kind of like a quick and dirty, easy test to do. Trigeminal and facial nerve test. I'm not going to make you guys do facial nerve, but you could take like a little piece of cotton or a little piece of paper and just like gently have the person close their eyes, gently like touch different areas in their face to see if there's any damage or if they can't perceive those sensations. And then the trigeminal nerve, you're going to have like 3 major branches, so you can see different parts of the face that might be affected, right? And then for the muscles of expression, you can just say, okay, smile for me. All right, good. Now frown. Good. Raise your eyebrows. Cool. Close your eyes nice and tight. Another thing that you can also do is while they're doing that, you can try to try to open their eyes up, and if you can try to test the strength of the muscles that innervate their eyelids. Right? I'm not going to make you guys do that because we don't have gloves or anything. I don't want you touching each other's faces. Another one for, let's see where we're at. So glossopharyngeal nerve, number 9. You could have them swallow a glass of water. And so you have them take a glass of water and you look at their Adam's apple, right? So their thyroid cartilage. And then you can see if the thyroid cartilage moves, if there's any sort of like abnormalities whatsoever while they're swallowing water. Vagus nerve, that's a little bit a challenging nerve to test. But if they complain of any sort of issues with their like heart, any issues with their GI tract, that could potentially indicate cranial nerve 10 issues. Accessory nerve, how do you think you would test that? Just literally have them shrug their shoulders. You can have them do it against resistance. You can put your hands on their shoulders and see if they're able to move against resistance. And then how do you test the hypoglossal nerve? Huh? Yeah, just have them stick their tongue out. And you can have them move their tongue from one side to another side. If they have hypoglossal nerve damage, then the tongue is going to deviate towards the damaged side, right? So if they stick their tongue out and it goes to the right, that's going to indicate right-sided hypoglossal nerve damage.
What was that? The type of, you said lockdown?
Locked-in syndrome.
So can they move the tongue?
No, there's 3 major types. The most common type, they're only going to really be able to move their eyes. They might be able to blink. They might be able to move their eyes. There's one that's complete like paralysis. Nothing moves. And then there's one where they can have like partial movements. I can't remember the full details on that one. But yeah, locked-in syndrome is a really scary condition. So we have 5 more minutes left. Let's go back to the beginning real quick here. And these are your 3 major regions of the brainstem. Was that fun, by the way? Was that cool? Yeah. All right, cool. 3 major regions of the brainstem. So you got your midbrain, you got your pons, and the medulla. If you're looking at a brain, if you're looking at a sagittal cut through this, the pons is going to be kind of like the first bump, and then the second and last bump is going to be the medulla before you get down into the brainstem. And you're going to find all your different cranial nerves coming off of the brainstem. And I would suggest already beginning to study these. Right? So I'm going to give you guys images of the brainstem. I'm going to point to an arrow. I'm going to have you know what cranial nerve is, what the nerve is, and what would it look like if that nerve was damaged. So off of the pons, you got cranial nerve number 5. What does cranial nerve 5 do? Do you guys remember?
Facial muscles.
Which ones? Yes, the muscles of mastication. Perfect. And what else? Sensation. Yes. Cranial nerve 5 and sensation, not quite. That's going to be 7. But cranial nerve 5 is going to be sensations of the face as well as the muscles of mastication. So like your masseter muscle, for example. So if I were to point an arrow there at the pons, at this cranial nerve, be like, what happens if this nerve gets damaged? Okay. What about like this one right over here, right? So your hypoglossal nerve, right? What happens if that nerve gets damaged, right? Then you're unable to protrude your tongue, right? Or you will protrude it and it will deviate towards the affected side. So make sure you are familiar with where those cranial nerves come off of the brainstem. So this is the embryonic derivatives of the different parts of the brainstem. So you're going to have the alar plate and you're going to have the basal plate. Those are the two major ones I want you to be familiar with. The alar plate is going to be what eventually turns into your dorsal horns. So that's going to provide the sensory input when the individual develops as a full adult. Then the basal plate is going to be what eventually turns into the motor derivatives, right? So it's going to be all part of the ventral horn as you grow older. Again, we're going to go into all this embryogenesis later on. So there's going to be more information about like the neural crest, the neural plates, and all that stuff later on. But this is just kind of like a very brief introduction to some of the major embryonic derivatives. So moving on, these are all the nuclei that you find within the brainstem. So if you did like axial cuts or transverse cuts throughout the entire brainstem, you'd be able to visualize the different nuclei that are associated with the different cranial nerves, right? So you have your ocular motor nucleus, right? Part of cranial nerve number 3. What else? You have parts of cranial nerve 5, the vestibular nuclei, abducens nuclei, cranial nerve 6. Sorry, vestibular would be part of 8. But I'm not going to have you guys remember all the nuclei that are on the brainstem. All I want you to do is be able to identify superficially those different cranial nerves and what those cranial nerves actually do. So let's see. Let's talk a little bit about the medulla before we wrap up for the day. The medulla is going to be the very last part of the brainstem before you get into the spinal cord. The medulla is going to be really important for a lot of your just basic, basic physiological function. Your heart rate, right? It's going to be also setting your respiratory rate, things like that, right? Some people can have severe brain damage to like parts of the cerebral cortex, but so long as, brainstem is still intact, they could still potentially live, right? Even without any sort of interventions, ventilators, etc. They could still potentially survive. There was a guy that I saw. This is another really sad patient. This kid with like cerebral palsy. We looked at his brain scan. They did a CT to see what his brain looked like. I couldn't believe it. It was like there was nothing there. It was just basically part of the brainstem, and that was it. Everything else was just filled with fluid. Right? Cerebral palsy is where you have some severe brain damage in those areas of the brain. If you look at a CT scan, those areas are literally just going to be filled up with like CSF, and that's basically it. So this guy literally had no brain. It was basically just a brainstem, and that was it. And pretty tragic because he has to constantly be under the care of, medical personnel and things like that. He was in the hospital for, I think he had an infection. And we'd have to go in there. He would like sit there with his mouth gaping open. You have to go in with a suction because he was still salivating, and you'd have to suction out the saliva. It was just really, really sad. But if you still have these regions intact, you can still potentially survive, right? These are the things that help maintain some of your most vital functions. So medulla, extremely important. Other things, vomiting, right? Hiccuping, swallowing, gagging, sweating, all that stuff is going to be moderated by the medulla. And on that note, we'll talk about the rest of part 2 next time we meet, next week. Any questions? Sounds good, guys. Have a wonderful weekend, and I'll see you next time.